Methadone has been saving lives in this country since 1972, and right now in 2026, there's a real political fight brewing over whether your doctor should still be allowed to prescribe it. That's not a hypothetical. According to Stat News this week, federal actions and proposals under the Trump administration have reignited a debate that addiction experts thought was settled science decades ago. And the medications at the center of this storm? Methadone and buprenorphine. Two drugs that if you or someone you love has ever battled opioid addiction, you've almost certainly heard of. Maybe you've taken them, maybe they're the reason someone you love is still breathing. So why is there suddenly a political fight over them? That's what we're digging into. Here's the part that catches most people off guard. These aren't experimental drugs, they aren't fringe. Methadone has been used to treat opioid use disorder in the United States for over 50 years. Buprenorphine, the other big one, got FDA approval back in 2002. Both of them are on the World Health Organization's list of essential medicines. We're talking about treatments with mountains of evidence behind them. And the evidence isn't subtle. Study after study has shown that medications for opioid use disorder, what clinicians call MA, cut the risk of overdose death roughly in half. That's not a marginal improvement. That's the difference between a funeral and a family dinner. So when Stat News reports that addiction experts and patient groups are worried about federal actions targeting these medications, you should understand what's actually at stake. We're not talking about a policy tweak. We're talking about the most effective tools we have against a crisis that's been killing tens of thousands of Americans every single year. Now here's where it gets politically strange. For a long time, support for these medications wasn't really a left or right issue. Conservatives, liberals, public health officials, law enforcement, a lot of them ended up in roughly the same place. The math was just too brutal to ignore. You either treat addiction like a medical condition with medical tools, or you keep counting bodies. But something is shifting, and that's what the stat piece is tracking. The reporting points to a reignited debate, with federal actions and proposals from the current administration putting methadone and buprenorphine back under scrutiny. The exact contours of every proposal are still developing. But the direction of the conversation, that's what has experts spooked. Why? Because there's an old idea that keeps clawing its way back into American drug policy. The idea that treating opioid addiction with another opioid is just trading one addiction for another. It sounds intuitive, it sounds like common sense, and it is almost completely wrong. If this is already shifting how you think about addiction medicine, hit subscribe, because the next layer of this story is where it really gets uncomfortable. Here's the thing about methadone and buprenorphine. Yes, they act on the same brain receptors as heroin or fentanyl, but pharmacologically, they behave very differently. They're long-acting, they're stable, they don't produce the same high, they stop withdrawal, they block cravings, they let a person function, hold a job, raise their kids, show up. Compare that to fentanyl, which can kill you in a dose smaller than a grain of salt. The notion that prescribing a controlled, regulated medication is somehow morally equivalent to letting people buy poison from a stranger, that idea has been studied to death. And it does not hold up, and yet the cultural suspicion never really went away. Methadone clinics have always been treated like something shameful, tucked into industrial parks, forced to operate under restrictions you would never apply to, say, a cardiology practice. Patients have had to line up every morning, sometimes before dawn, just to get their dose. For decades, buprenorphine was supposed to be the more accessible option. It can be prescribed in a regular doctor's office. It can be taken at home. For years, though, doctors had to get a special waiver just to prescribe it, which kept the number of providers artificially tiny. That waiver was finally eliminated in 2023, a genuine win for access. And now the worry from addiction experts is that the political winds are shifting backward, that the hard-won gains in access could be reversed, that the medications themselves could be reframed, in federal policy, as part of the problem rather than the solution. Think about what that would mean. Picture a small town that finally, after years of overdoses, got a clinic that prescribes buprenorphine. Picture the people who finally stopped dying. Now picture the funding pulled, the clinic closed, the patients sent back to whatever they were using before. That's not a dystopian thought experiment. That's the scenario addiction specialists are quietly preparing for. And here's the cruelest twist. We already know what happens when you cut people off from these medications. We have decades of data. When patients lose access to methadone or buprenorphine, their overdose risk doesn't just creep up, it rockets. The period right after someone stops MAUD is one of the deadliest windows in all of medicine. Their tolerance is lower, their cravings are still there, and if they relapse, the fentanyl-soaked supply out there is waiting. So when patient advocacy groups say they're worried, they're not being dramatic. They're reading the same studies the rest of us could read, they're doing the arithmetic. There's another wrinkle here worth sitting with. A lot of the political pushback against MUD is wrapped in the language of recovery and abstinence. The idea that real recovery means being completely drug-free, no medications, no crutches, just willpower and a higher power. That framing has deep roots in American culture, going back to the 12-step movement. And for some substances, for some people, abstinence-based recovery genuinely works. But opioid addiction is different. The biology is different. The brain changes that opioids cause can take years to heal, if they heal at all. And asking someone with severe opioid use disorder to white-knuckle their way through, in 2026 with fentanyl in every corner of the drug supply, that's not recovery. That's a coin flip with their life. Doctors who specialize in addiction medicine will tell you this plainly. The most effective treatment, the one with the strongest evidence base, is medication combined with counseling and social support. Not medication or counseling, both. So why does the politics keep drifting away from the medicine? Part of it is stigma. Part of it is the deep American discomfort with the idea that addiction is a disease rather than a moral failing. Part of it is cost, and part of it, honestly, is that the people who benefit most from these medications are often the people with the least political power. Quick favor, if this is the kind of story you wish more people understood, hit the like button. It genuinely helps this kind of reporting find the people who need it. Now, the Stat News piece doesn't claim that methadone or buprenorphine are about to be banned tomorrow. That's not the story. The story is that the consensus, the quiet bipartisan agreement that these medications save lives and deserve federal support, that consensus is fraying. And once it frays, policy follows. You can see it in the kinds of proposals being floated. Changes to how MUD programs are funded. Changes to how they're regulated. Shifts in the rhetoric coming out of federal agencies. None of it is one dramatic announcement. It's 100 small adjustments, each one a little harder to access, a little easier to defund, a little less central to the federal response. And the people sounding the alarm are not partisans. They are clinicians, researchers, parents who have buried children, people in long-term recovery who credit these medications with their lives. Here's what makes this moment so strange. The opioid crisis hasn't gone away. Overdose deaths have started to decline from their peak, which is real progress, but the numbers are still staggering. Fentanyl is still everywhere. The pipeline of new patients hasn't slowed. This is exactly the wrong moment to start dismantling the tools that work. And yet, here we are. The medications that the World Health Organization calls essential. The medications that cut overdose death in half. The medications that, on any honest reading of the evidence, are the closest thing we have to a miracle in this entire crisis. Those are the medications now being relitigated. So what should you do with all this? Honestly, the first thing is just to know it. Most Americans, if you ask them, can't tell you the difference between methadone and morphine, can't tell you what buprenorphine does, can't tell you why a doctor would prescribe either one. That information vacuum is exactly where bad policy thrives. The second thing is to notice the language. When you hear someone talk about mood as if it's just replacing one drug with another, you'll know that's not what the science says. When you hear addiction framed purely as a choice or a moral failing, you'll know that framing has a body count. And the third thing is to pay attention to who's actually treating opioid use disorder in your community. Because if federal policy shifts, those local clinics and prescribers are going to be on the front line. They're going to know first. The people who built modern addiction medicine spent 50 years dragging it out of the shadows. 50 years of studies, of advocacy, of patients telling their stories. The idea that any of that could quietly slide backward, not because the science changed, but because the politics did, that should bother you. Because the next overdose statistic isn't a statistic. It's somebody's kid, somebody's parent, somebody who, with the right medication and the right support, could still be here next year. And the medicine to keep them here already exists. The only question is whether we let them have it. If you want more stories like this, the ones your doctor probably won't have time to tell you, subscribe and stick around. There's a lot more coming.